Hello folks, welcome to another SACPA session. SACPA acknowledges that this event takes place on the lands of the Blackfoot people and Métis Nation of Alberta Region 3, and we pay respect to their past, present and future cultural heritage, beliefs and relationship to the land. SACPA commits to assist reconciliation efforts by raising awareness of the ways past and present injustices can be reconciled. Today we're very happy to have with us Dr. Samuel deWalle, or deWalle, if I want to say it in total Dutch fashion. Welcome and thank you for joining us. Dr. Samuel deWalle is a family physician living and working since 2013 in Lethbridge, Alberta. He graduated from Calvin University in Grand Rapids, Michigan, and then the University of Calgary Medical School, before completing his residency in rural family medicine in Southern Alberta. He's the outgoing president of the Family Medicine Clinic in Lethbridge, a board member of the Chinook Primary Care Network, a Civil Aviation Medical Examiner, and a medical school clinical lecturer. And I will say also that all options stated are his alone and do not represent any other business or institution. Thanks very much for joining us, and we very much look forward to your talk.
Yeah, thanks for having me. I want to thank the organization for giving me the opportunity to talk on this subject. When I was preparing this, so, we have a title for this talk, but the thing I wrote on the top of my notepad was the death of family medicine. It was a little more succinct, maybe over dramatic, but it does kind of play into the reason that this is an important moment in not just Lethbridge's history here in terms of healthcare, but probably Alberta more broadly. And to back up a little bit, those are a list of things that I do. Most of what I do is family practice. I am a doctor who sees you when you come in sick for some reason in your medical clinic, and that's what a lot of people think of as their physicians. There's lots of different sorts of us though, but that's what I'm going to be focusing on, the family practice element, the primary care practice of medicine in Lethbridge. So when we give talks in medicine, we want to go through disclosures that everyone who has a medical background knows. If they are at a conference, they'll have the first slide saying disclosures. I'm paid lots of money by this organization or that organization, so you should either trust what I say or not. I don't have any disclosures. I talked to many different individuals and organizations trying to get opinions and data. But if I made an error with that, with anything I tell you here today, that error is mine. I would ask that I should run this by a lawyer. Can I say that by continuing to listen, you consent to not being angry at me and relinquishing ability to get me in trouble? I don't want anyone communicating with an organization I'm associated with saying, oh, that deWalle did something. Oh, this is all just on me, or going as far to talk to Canadian Tire to get me because I use Canadian Tire money and use that. And anyway, any mistake is mine, and I can't emphasize that enough. So what are we really talking about here, and where do I start, and how do I focus in? So when I was asked to do this, physicians thinking objectively a lot want to present data. We want to present experiment type things. We want a control group, and we're just not going to be able to do that here. So I struggled with this for a while, and then I just bumped into a mentor of mine who taught me in residency, and I kind of explained what I was thinking about here. He said, oh, don't do that. Not everything has to be a randomized control trial. Just tell your story. I thought, well, I can do that. Anyone can do that, and I'll do that. And so why might you want to hear it? It's complex. I know people want to hear it because I'm asked about it 5 to 10 times a day, it feels like. And by doing this, I hope to give people a peek behind the curtain of what's going on here. And the reason for that is that 45%, roughly, of our city of about 100,000 people, or a small city, does not have a family doctor, does not have a place to go, a clinic that they can call their home. And people deserve to know why. Why is that? Because that didn't used to be the case. So I'll tell my story. I don't know at the end that would have like a slide that says, and these are my conclusions, and this is where to go from there. Ultimately, I think maybe you can glean something from what I talk and draw some conclusions yourself, more or less. So the getting into a little bit of the details, I was a little bit perturbed to talk to some members of government who were not really aware of how many family doctors there are doing primary care. They had to be informed by us, even though they're making decisions before talking to us based on information that seemingly they didn't have. But the numbers of physicians doing primary care has dropped quite a bit recently. At the end of 2019 and into 2020, there were about 88 doctors who do, more or less what I do here in town. By the end of 2021, that number was at 69, and that number is dropping further. I'm getting asked daily by several people to take them on, to take their family members on. The hospitals are discharging babies to nobody, right? There's long-term care organizations trying to find someone to watch your grandma, and struggling to do so. So I'll try to zoom in and out on the big picture and the small picture a little bit as we go. Going backwards in time as well, I was tempted to go back all the way to Ralph Klein, but I wasn't really there, and I'm not going to do that to you. But really, since problems in the past, there have been a slow building in primary care, in being able to access a family doctor here in Lethbridge, and more broadly as well. So roughly, when I graduated in residency, there were still pieces of paper in the front of the emergency room. These are doctors who would take you on, and there was maybe one or two names or no names on that list. And as time went on, that list began to get longer. And so somewhere between 2014 and 2016, we were at a place in Lethbridge where if you wanted to have a family doctor, you could have one. There were consistently people accepting new patients, and so much so that people would move from one physician to another because that clinic was closer to their house or some other cause. The communities in the area, more rurally, had more physicians as well. It's important to notice that we never found what's called a medical home, which is a term that I really like, for everyone in town. At best, we got down to about 10,000 people in Lethbridge not having a family doctor. But the resources were there. Furthermore, we had, as in my clinic, we had the ability to run 10 evening or urgent care clinics in a week, per week, in two different locations. We had about 20 to 23 physicians at any given time. So at that point, we're at 88 physicians, and it's important to step back and say, why is this important? Why should I care about this? There's a lot of different reasons for an individual wanting to be able to have their kids seen if they have an ear infection. That's important to you. From a more systemic perspective, most healthcare encounters are in primary care. They're in rooms like I'm sitting in right now. There's also a lot of evidence from a systemic standpoint about how important this is. Primary care, robust primary care, is associated with improved access to healthcare more broadly. It's associated with improved health outcomes, decreased illness, decreased mortality across the population. Robust primary care, and if that system is in place, is associated with fewer hospitalizations. It's associated with fewer emergency room visits. To some degree, although not a complete degree, it is able to negate some of the social and environmental aspects of health that are very important. Poverty, accessibility, these sorts of things. Obviously, nothing is ideal for that, but it does make a difference. There's research to state that is the case. In the recent throne speech, Premier Kenney said, well, we need to get more bang for our buck from the healthcare system. If that's the case, we need to be talking about primary care. Nobody ever talks about primary care. It's not the most interesting form of medicine to a lot of people. We like talking about ICU beds. We like talking about how fast you can get a knee replacement, and that's fine. But primary care needs to be into that discussion for very important reasons. So here we are, we're 2018, 2019, we're sitting at about 88 physicians here. We're able to do all these different things. In the background, in the end of 2019, we start hearing rumblings of coronavirus. So for those of us who are paying attention, there's this virus abroad, early indications say it's got a mortality rate of between 1 and 3.5%. Those numbers sound small to someone not in medicine, sound horrifying to someone in medicine because of the transmissibility being so high. And that has a bit of a chilling effect on people. And so as I talk about other things, political things, just remember that that's kind of in the background. That's, first conceptually and then very much in practice. And well, we all know where we are with that now. But the 2019 comes around, and this is still the big picture here in Alberta. The government of Alberta creates or asks for this report. They call it Blue Ribbon Panel, McKinnon Blue Ribbon Panel report. I don't really know what the blue ribbon stands for, other than take this really seriously. This panel has a blue ribbon on it, so it is extra important, extra special. And in that panel, in there, there's a narrative that started. Doctors in Alberta are overpaid. And you see that being caught or taken up by some of the right-wing columnists, and so it's a bit of table setting for what's coming next. And so in October of 2019, the government tables a bill called Bill 21, and this is really important, and this is what physicians have been talking about at length amongst ourselves for a long time. In Bill 21, the government gave itself the right to unilaterally terminate an agreement or contract with physicians. It also gave themselves the right to say in any theoretical future contract that was signed, the government would have the right to extricate itself from it unilaterally. And so when I talk with people, I said, well, let's say you're working for an organization doing whatever it is you do, and the organization says, that contract you signed, we can change that without running that by you at any time. Is that okay? Probably most people are not really okay with that. It would have a bit of a chilling effect. At that time, the government was also talking about taking control of where you could practice. So if you graduated from a medical school here in Alberta, they were saying, well, you can only practice in these 4 areas, but we have enough physicians in these other areas. So conceptually, that makes some sense. That's been tried in other provinces and not found to be particularly effective, but the government was talking about going that way. Now, meanwhile, the contract between Alberta physicians and the government was expiring, and there was negotiations between the Alberta Medical Association, which is, represents physicians, and the government in February of 2020. Mediation to create a new agreement had failed at that point, but there had been an agreement to continue negotiation until February 29th. However, on February 20th, 2020, the government used their newfound powers and terminated that agreement, the master agreement between Alberta physicians and the only employer we can actually work for, which is the government. We didn't get any notice of that. We learned about it through the media. And this kind of thing hasn't been done before in Canada. It's pretty important. It's pretty groundbreaking. So that had seismic reverberations through the medical community here. I can't overstate how much that was taken poorly. In March of 2020, we're also talking about COVID lockdown at this stage, right? The government institutes changes at that point as well to how physicians are paid. And so they're going to say, well, we're going to change the contract. We're just going to do it, and that's what it's going to be. So they did a number of changes, and most of those changes, from my perspective, targeted primary care. We, in primary care, lost the ability to have more remuneration for taking on very complex patients. There was a planned discontinuation of being able to spend more time with patients. And they also did this thing called an encounter cap, and that's been in the media a little bit. Oh, you can't see more than X number of patients per day. It's not actually accurate. The encounter cap basically said, if you're a physician, you can't have more than 50 encounters per day, basically. So, if I get called by a pharmacist, or if I speak to the phone with a specialist for advice, or if I answer a fax from long-term care, these are all encounters. And so that basically stopped us from being able to do evening clinics. There were too many physicians who said, well, I did too much today. I can't do more. And we couldn't ask the remaining physicians to run as much walk-in as we were doing. And COVID had a chilling effect on that too. So this is my guess, but in polling different physicians around, the guess is that most family doctors' income may have dropped between 10 to 25% at that time. We were also doing virtual care as well, which wasn't heavily supported by the government. That's maybe a contentious statement, but I'll stick to it. At that time, the AMA started talking about suing the government as well. As it's very contentious, right? Because the loss of some of the rights for arbitration. So I won't get into it too much, but we go then to April 2020. The government turns around and makes a great fanfare of reversing some of these changes if you're in a rural place. And they said, look at all the wonderful things we're doing for rural medicine. And, you know, within a lot of those discussions were basically all the good things they had done and just reversing the bad things they had done a couple months earlier. That was frustrating for everybody. But you know, Lethbridge not affected by that. We still have our cash. We still can't do our urgent care. We still have all the same issues. At this time as well, this was absolute bizarro world. Doctors basically had to create Twitter accounts to follow the health minister at that time to know what the terms of employment were going to be, because this is how we would hear news, right? Thursday evening, there'd be something on Minister Chandra's Twitter page that would say, oh, I guess this is how things are now. And then we'd hear about it through official channels the next week or 2 weeks later. Weird, right? Just kind of weird, right? Anyway, I wondered about how much to talk about this next thing, and I'm just going to mention it because some of the implications of it I don't think have really come yet, but I want people to watch for them a little bit. July of 2020 is where we're at in this story now. Bill 30 comes through. The government passes Bill 30, or tables Bill 30. They talk about taking over the College of Physicians and Surgeons of Alberta. I don't want to get into it too much, but that's a regulatory body, and in most places the physicians are self-regulating. Like if someone gets in trouble as a physician, it's other physicians that decide what should be done with them. Ultimately, it's a very simplistic way of putting it, but the government taking over on that subject would had an extremely chilling effect, and just talking about it was concerning. You have to remember that at a point in this process, there was a physician who shared a meme on Facebook and had a health minister show up on his driveway yelling at him and his kids. That's not something that you would want running your regulatory college. At this point, though, in Bill 30, there was discussion of more privatization of surgical facilities, and a corporation could contract now, this in the wording of this bill, to provide you with health care. Previously, only physician or physician organization can do that. My problem with that, of course, is corporations don't take a Hippocratic oath, right? And so they have different things that they want, whereas we are designed to, be patient-oriented in that regard. Anyway, over that time, the Alberta Medical Association is still trying to negotiate with the government, being mainly ignored. Shortly after, Health Minister Chandro writes to the college and says, if you leave your job, particularly if you're rural and you leave your job or threaten to leave your job, that's going to be considered job action. And you, of course, are not allowed to strike. So if you do that, we will, you can't. We're going to force you to provide services. And if you want to leave, you have to find a replacement, or this is the rumbling at that time. Anecdotally, in speaking with people who were coming out of where they had been trained, which is a bigger center usually, and they had been going to these smaller places to check it out or do locum work or do some training, that had an extremely chilling effect. And I said, well, what do you mean? If I want to set up here, I might not be able to leave if I still want to work in the province. If I have to set up here, I'm responsible for finding someone, to take over if I can't do it anymore. Why would I do that? Why would I do that to myself? So it was an attempt to stop people who are currently there from leaving, but had quite a chilling effect on people who were looking at coming. By definition, quite short-sighted. So July, Bill 30 goes into force. We get a Alberta Medical Association's vote and non-confidence in the health minister. 98% of people who vote that they do not have confidence in the health minister. Zooming in a little bit to Lethbridge, particularly around this time, we're having physicians leave. And that's not unusual, right? We have more than normal, I think, but there's always turnover. That's just the nature of things. We have some attrition due to health, even death. We have a couple of significant losses. Mention is not a family physician, but Dr. Edwards. We miss him greatly, and a Dr. Nasisi. We miss him greatly as well. But very tragic losses, but also people just moving away, and for different reasons. Some of them political, some of them not wanting to put up with things, and we have retirements as well. But we're not replacing these doctors. They're not being replaced. Nobody's coming. The clinic undergoing more strain. My clinic as well. All the virtual medicine we're doing has a decrease in income significantly for the clinic, which is a non-profit outfit basically, but it's starting to get strained. There's business disagreements between different physicians, a fracturing of opinions about what to do about this. Meanwhile, the government makes more noise about taking over regulatory duties for the College of Physicians and Surgeons of Alberta. As an aside, that's a red line for me. I would not work in such a manner. That's non-negotiable for me. But as we get to September of 2020, the government starts talking about a sunshine list. Oh, we're going to push back against you here by publishing everyone's income. When you see a sunshine list and it has, for example, a politician on it or something like that, that probably underestimates the income that person has, because it includes benefits and pension. When you see a sunshine list with a physician, that will overestimate their income, because it's simply a gross income. Like the physician's income is a business income. We have to pay for, having the lights on, having staff here, using our computer different programs, insurance, all that kind of stuff. So that didn't go over very well with physicians either. Back in looking at Lethbridge at that point as well, the situation continued to fray. With more financial uncertainty, physicians were moving from clinic to clinic, trying to find something different. Still no new physicians. At a point a little while ago, I asked the University of Calgary residency programs in different functions to tell me a little bit of what they knew about new physicians. Like, where are these family medicine graduates going? Unfortunately, they didn't have a whole lot of data. There's not a program to really watch these things. But from what I could glean, a lot of people were either, shortly after training, they were leaving the province, or they were returning for further training. Right? They're going to pick up an additional year or two in different things. Just did not feel like the time that people wanted to set up a practice. This was the general insight that I received when I, made questions about that. So roughly in October 2020, the College of Physicians and Surgeons reports that, the amount of physicians is mainly stable. That was picked up by the media quite a bit, but it was not accurate, because what that was is just counting who had an active license. If you had an active license, you may have left earlier that year, but your license is still there. It's still active. There was a survey at that point. It said about 42% of physicians were thinking about quitting or leaving Alberta at that stage because of the environment that they were in. It was probably accurate. I think that sounds about right in speaking to my colleagues. So we'll fast forward a little bit to 2021, just as a note, vaccinations coming out for COVID, that was a huge deal. So there's one for the win column, really. But then we get a tentative agreement reached with between the Alberta Medical Association and the ministry. And so that sounds like a ray of light, sounds like stability coming forward. But you have to remember what I said about Bill 21. If the government doesn't like that contract later, they can cancel it again. There's no binding element to anything we sign. So the vote proceeds. 53% of people say no. Now, I've met actually with the new health minister, who seems like a very reasonable gentleman and not likely to show up on my driveway. But I asked him, well, why do you think that was? And he thought for a minute, and to his credit, he gave us some thought. He said, well, I think there's an element of anger there. I think probably he's right. Furthermore, though, the fact that this was non-binding was really a non-starter for a lot of people. It's just like, well, who cares what's in it? Who cares what's in this agreement? Who cares if it provides stability? It doesn't actually provide stability, because if you don't like it next month, it's gone. Maybe that's oversimplification, but that's how we felt. So the Alberta Medical Association after that returns to the table, even though there's no formal negotiations. Zooming into Lethbridge a little bit, in the summer to fall of 2021, the clinic loses some critical mass. My clinic does, right? It survives barely, but we have to downsize and remains vulnerable to this day. Now we're at roughly about 12 physicians. We don't have any after hours care. We're not doing any urgent care. Remember before I said we were doing 10 clinics a week, probably seeing maybe roughly by my back of the envelope calculations, 250 people a week, often who had no family doctor. It was just a point of access that simply just isn't there anymore. Population hasn't gotten smaller, but the access has worsened across the board. Like I said, babies are being sent home without physicians from the hospital. I just think that's unreasonable. That's insanity. We should not be accepting that. Cancer patients, knocking on our door. I need a doctor. That's heartbreaking. It should never have been allowed to get to this place, right? I would say I hear between 2 to 5 sad stories per day, and it's really a challenge. You do the best you can to help people access care, but there's only so much we can do as individuals, of course. By the end of 2021, the physician numbers in Lethbridge of people who do roughly what I do have gone from 88 earlier to 69, and I suspect have dropped a little bit further since then as well. The end of 2021, Health Minister Shandro is replaced with Health Minister Copping. And to his credit and our MLA's credit, actually hosted a number of family physicians at the end of 2021. And, I don't know about the implications of that, but what I do know is that they did take the time to sit and listen. And I really respected that. I was a little concerned that the people there, when asked about some things, weren't 100% sure themselves of the changes that the government had, of what they themselves had done. And some of that needed to be explained to them. So I had a fear that basically people were looking at spreadsheets and just Xing things out without knowing what exactly they were doing. Regardless. So that brings us pretty much to today. That brings us to where we are now, which is maybe more of a stable place compared to the next, or compared to the last 2 years, roughly. I hope, but not out of the woods by any means. And I think a lot of what's going to happen next will make a big difference in how we go from here. I want to point out a couple things, though. The reiterating the benefits of primary care here. We have to remember that it's cheapest. It's the cheapest, most cost-effective healthcare that we have. So if you've got an issue and you come in and you see your family doctor, to have the lights on and the computer system and all the people who they see you, it costs about $40 to the system. If that same patient goes to the emergency room, the starting cost is 10 times that. 10 times that. So again, I hate pointing to, late night urgent walk-in or night clinics that we're running, to have 250 people per week. Even if 15, 20, 30% of those people will filter over to the ER, and I suspect it's that higher, that's a net significant loss in both access, and it's a net increase in cost. But to remind people, there's a foundational benefit there to the health of a society and the health of individuals within it, to have robust primary care. The government needs to be talking about that more. If they're talking about increasing ICU bed capacity, the next sentence should be, and then what we're going to do about the primary care problem. Keeping you out of, and your family out of the emergency room, keeping you out of the hospital, stopping little cancers from becoming big cancers. Improving mental health so that the first time it shows up isn't with a suicide attempt, right? This is what we're talking about here. We're not talking about family doctors. We're talking about those things, deeply important things. Had a bit of an informal poll with my colleagues. I said, well, why were the majority of the cuts the government made to primary care? The majority of what they did were aimed at the people like us sitting in clinics like these. The answers were basically boiled down to two things. Either the government didn't know what it's doing, or it did, and it's trying to destabilize things prior to attempt at privatization. But ultimately, we're guessing. We don't really know because they haven't told us. So, like I said, I wasn't going to have a conclusion here. I'm not going to be able to say, look, this is the three main points. It's just a story. It's just a story of where we are, and I'm not the main character in it. Things don't look that different for me now. The main characters are my patients, and more importantly, the patients that I used to be able to see, and now I'm not. The patients who had a family doctor here now don't. So I hope if me talking about this has helped shed any light on that helps somebody. I did put the call out with a couple of questions to a number of different colleagues, and just said, well, do you have any perspectives here? So if I've got about a minute left or so, I'm just going to mention, go over a few things of what they said. So one person says, to fix this, Alberta Health can allow a mandate to recruit international medical graduates. Okay, yeah. Alberta Health needs to come to an agreement with physicians, and the general tone of communication needs to change to be more conciliatory. Trust is broken and needs to be carefully rebuilt. All right. Another person. I think the healthcare system is undermining the future of family medicine in Alberta. I think the government needs to start reimbursing the specialists way less and needs to start paying family physicians more. They have financially disincentivized family medicine. This is leading people to not want to do family medicine residency at all. And from what we've seen in the last 3 to 4 years, those who are doing a family medicine residency are doing a third year in ER or anesthesia, and therefore never working as family doctors. The pay scale is misaligned. For example, I can make $5,000 in a 24-hour shift in the hospital or ER in a weekend. That's what I make in a full week working family medicine. But where we struggle to staff our clinic, pay our rent, purchase supplies, and we work all evening doing paperwork to care for people that in very difficult situations. Family medicine requires struggling with difficult people and difficult problems for months and years on end. The system is backwards. Physicians, few of us feel valued, especially family doctors. All right. Another physician. The bigger issue in the long run is comprehensive care, the willingness of physicians to take on more and more difficult patients. We need to be very vocal how the early 2020 changes messed up the motivation to do that kind of practice. All right. Another person. Lethbridge had a larger number of near retirement physicians also, which added to the storm as many were scheduled to retire and the rest decided to step out early. Okay, yeah, that's a great point. I didn't really touch on that too much, but I think Lethbridge just had some vulnerabilities that we just got unlucky with that, and that's probably true as well. Another person. Problem is that there's not a lot of doctors out there who are prepared to take on the responsibility, stress, and burden of a family physician practice. For sure not with the current uncertainties. We may have to step outside the box for more immediate help for people without doctors. Government may have to step up and make clinic space with staff to allow new doctors to work on a locum basis to test the waters. Doctors may be willing to trial practice here if they don't have to take on the burden commitment of overhead initially and so on. So, yeah. So I got a number of responses, a whole bunch of things that I didn't respond to, but those are kind of a little sampling of some of the input from people. So. I'm very happy to take some questions. I don't know if people have any. I don't even know if I'm going to have excellent answers, but I'm happy to hear them.
Thank you, Dr. Samuel. That's a very informative talk. We have lots of questions, so I'm going to jump right in.
Oh, okay.
Ian Hurdle, yearly third quarter family doctor numbers are a combination of. Oops, sorry, it just jumped out of my screen. Let me start again. Yearly third quarter family doctor numbers are a combination of new doctors starting and ones leaving whose licenses lapse at year end. In 2019, plus 35. In 2020, plus 75. In 2021, minus 30, meaning a real loss of 165. Yeah. What are your comments on that?
That's fair. I would also say that, what I really want from government in terms of data, and I don't think they give us, like, if we can do better than that, actually, government can tell us who's actually working, who's seeing patients. They have that information. But I've not been able to dig that up. I think the rest is just kind of guessing. There's a lot of people who keep license. I know doctors who have moved to out of province but kept a license. they're not working here, right? So these are just ways to be able to estimate things. What I can tell you, and the best data that I have comes from our primary care network here, is that the numbers of patients actively working has dropped with great significance, as high as 30% or higher within our primary care network zone, which includes, Lethbridge, Tabor, out to Crow's Nest Pass, down to Milk River, these kinds of areas. That's a massive loss, and it takes a long time to rebuild. The post-Klein era kind of showed us that you can destroy something very quickly. To build it back up takes a lot of intentionality and a lot of time. What was distressing to me is that politicians were coming and saying, well, this is how many family doctors there are. And their numbers were insanely off. They were clearly counting people with license doing very different things or not working at all. People who are, if you have the same credentials as me, but you work only in, for example, a wound clinic, doing very important work, but you're not doing primary care, you're being counted in their numbers. They have the ability to know better than that, to know who's actually doing the work that they're interested in. So that was one of my frustrations looking at that.
The next question comes from Bev Mundell. There have been fewer residency positions in Alberta than students graduated from med school for ages. So Alberta sends to other provinces for residencies.
So it's a really complex thought, right? We have at different times in medical schools had, by the year, there's sometimes open places for family medicine, which is what I'm most interested in. You have to remember too that Alberta has 2 medical schools. Other places are not as richly blessed with medical schools as we are. I don't know how much of an opportunity can be gleaned from that, because I think that's probably where you're going with that question, like what could we do here that would be different. One of the things in speaking to the rural coordinator of the University of Calgary, rural medicine, which is the residency I graduated with, rural family medicine, is that there's talk of having more satellite residency type experiences outside of the major centers, and I can only suggest that that's a really good idea. It's hard enough for family medicine, but specialties are like this as well. If you live for a long period of time at the stage of your life when you're in medical school and residency, there's a good chance you've got kids and they're in school already by the time you're done. So to move to a place that's underserved at that time is a significant uprooting for you. I think there are opportunities there, without a doubt. Like I said, I'm not speaking on behalf of any medical school here.
Ian Hurdle has Ian Hurdle has a second question. In the 50s and 60s, 50% of doctors came from the UK. In the 70s and 80s, 40% of surgeons trained went to the US, followed in the 80s by lots of new and jobless RNs. Are we losing our next generation of health workers?
I'll speak to family medicine. I think family medicine is in trouble. Health workers more generally, I think we could have that talk. It would probably take a long time and have a lot of conjecture. But what I'll speak on is family medicine. I find that when I was in medical school, there was this push to say, yeah, well, you should do family medicine. Family medicine is valued. Over time, I'm not sure if I see that same thing. If you're in medical school at the moment, you think, well, I can do something that is different. I'll specialize, and I feel like I'm a little bit higher on the totem pole. I feel like I'll make more money. I'll have more prestige, and they're not wrong. The people who feel that way. The problem with that is that, like I said, the evidence for family medicine is really, really robust. I personally have a couple of ideas about what could probably be done a little bit differently about the residency and how we could, emphasize some different things with it. But that's my fear, is that, we're gonna be looking at something in the long term here that is pretty seismic for primary care, which we should care about a whole lot more than we do. We take it for granted. because it's not interesting enough. We don't know what it is until it's gone. I think people are starting to realize that now. I hope they're starting to realize that now. I don't know. Sorry, that's a long way of saying I'm not going to give you an answer, Ian.
Okay, our next question comes from Leona Jacob. What do you know about and what do you think about the city of Lethbridge's intention to engage in doctor recruitment?
I know it was talked about in the campaign, in the campaign from several people. Lethbridge is a good place to work. Lethbridge can recruit itself. We're close to the mountains. We've and I spoke to another physician who said traditionally you're not going to get too much sympathy talking, being from Lethbridge, to some of the other, it's not remote, but these population centers in other areas that aren't the big cities. Lethbridge is close to the mountain. It's got lots of amenities. It's a good place to be. The problem, I think, is more structural for Alberta, and if Alberta does well, Lethbridge will do well. And it's the problem can be tied back to like how and where we're treating our residents. If that goes well, Lethbridge will do well. If we can, okay, so the problem is that Lethbridge doesn't really have the ability to address the problems that we're talking about. Is Lethbridge going to campaign for contract stability for physicians? It's kind of outside of its mandate, right? So I think it comes across as a nice thing to say. I just don't know what it can mean really in concrete fashion to kind of address the issues at hand. Unless Lethbridge wants to get into the business of building brick and mortar clinics and staffing them, which I don't think is a pathway that most municipalities would want to go down.
Okay. Our next question comes from Laurie Schultz. In a Lethbridge article this week, the Honourable Grant Hunter, UCP MLA for Taber, stated there was not a shortage of doctors in Alberta, that it was an urban/rural distribution problem of doctors.
Yeah.
Hunter spoke of a rural program that was to be implemented. Lethbridge would not be eligible for this program. What are your comments?
Yeah. I'm very tempted to just decline the question because I don't want to get myself into trouble. But at different times, the rhetoric from politicians would be like, "Oh, this is not a problem. This is not a problem," and people know if they have a problem or not. People know if they can't go see their doctor. So I would advise you to take anything. People know what their own situation is, right? And if you don't have a doctor to go to, you have a problem. You have a problem. These are the same groups, people who called our situation in Lethbridge a micro situation. This is just rhetoric that I don't have much time for. And you can see that people are flinging things out of the wall to seeing what will stick to try to dissociate themselves from what may be going on here. The concern, of course, is, and what the government has tried to do is to say, well, we can solve that problem by just offering people that they can only work where we have a need, right? So, well, there's not going to be any more. You can't start work as a family doctor in Calgary because we have enough family doctors there. Okay, it makes sense, right? You can, if you want to start working, you can work in these 5 communities. Okay, logically that makes some sense. The problem is it's been tried before in different provinces and it didn't help. It didn't help. So I don't want to be saying you must trust the free market in terms of where labor goes to a need, but the alternative hasn't seemed to work any better. And that's probably all I'll say about that because I don't want to ruffle feathers the wrong way. But I would just suggest don't let politicians tell you if there's a problem or not. You can yourself.
Okay. Our next question, another question from Laura Schultz. Is the encounter cap still in place?
Oh yeah. Unless I've missed some massive announcement in the last little while. And this is conceptually, I didn't really mind the encounter cap. I mean, if I get to the place where I'm seeing like a lot of people, I'm like, well, for me personally, that's a struggle, and it's probably just not going to affect me too much. Where it does affect me though, and where it would have affected me and did affect me is once every 2 weeks or so, I would have dinner and then I would come back here and I'd see a bunch of people in the evening with other issues. And that was okay because I didn't do it all the time, right? And I would do it on, at different times. And so I felt that I would be able to work as my best self as a physician, and occasionally on certain days stretch myself quite a bit. The government can't be too concerned about it because they said, well, it doesn't count if you're in a rural place. So if you're in a rural place, physicians are, I don't know, are different, I guess, that they work fine after working a lot. And so that's fine, but it's not okay for us here. So um, conceptually, I didn't mind it, but the implications have been fairly profound, I would say, with that. I did ask a number of my colleagues. I said, well, if they lifted that, because this is some of the rhetoric too. If we lift the encounter cap, can you all see more patients? That would be how we get out of this mess. I would say 95% of the people that I asked who work in Lethbridge here said, I can't. Either mostly because I'm too tired. Mostly I'm too tired. I'm not capable of doing more. Even if we were able to open up evening or we clinics or something like that at this point, I don't have the strength to do them. Okay. Ultimately, and that's sad too, of course.
Mark Goodall, is ER now taking place of primary care for those without a family physician?
Yeah.
And if so, how are they coping, and is it not costing the government more?
Such a good question. I would love to provide you with the data to really back up what I'm going to say. So I'm going to give you kind of some half answers here. We know that numbers of visits to the emergency room haven't spiked quite to the degree that we would have thought of. Anecdotally, the reason for that, as far as I can tell, is in speaking to my own patients, is that people are terrified to go. People are terrified to go to the emergency room. I've had patients almost miss blood clots in their lungs and things like that because they just did not want to go there, either because they have a feeling that the wait times are egregious. We could have a debate about that, of course, or that they're going to get coronavirus. This big scary place that we're going to get coronavirus. So we have a lot of talk with people about when to go to the ER, and the ER is a fantastic resource and we need to use it in certain circumstances. In speaking to an ER colleague or two of mine, there is some of that. There is some people going in, I need my prescriptions, or can you help me with this and that? But the ER is not really set up to do what we do. They're not set up to do cancer screenings and periodic assessments and kind of the slow, hard, grinding work of walking through depressive or mental health crises or something like that. That stuff is filtering into the emergency room. It's not the right place for it. You're going to get, not to say that my ER colleagues aren't capable of doing it. It's just the system and the structure is not right. It's not right for doing it. So I think what we're going to see more of is people going to their pharmacists to, get refills of the same medications that they've been on, even though they don't have a family doctor anymore, and the pharmacy will, check their blood pressure, to just skating along until we can do something better. That kind of thing is that people will be using that TELUS product. It used to be called Babylon. That sort of thing. We'll have just these bandaging patchwork changes here. One of my colleagues did point out that when a lot of family doctors left Lethbridge, they gave people as much medications as they could. Well, you've got diabetes, you've got hypertension, you've got depression, you've got whatever. I'm going to give you a year of medication, and for a lot of those people, that year is coming up. What are we going to do? I don't know. I don't know the answer to that. So great question. I can't answer it well enough, but it's on my mind for sure.
Clint Peterson, private healthcare is arguably the aim of the UCP ideology, and the best way for them to make it happen is to undermine public health. What are your thoughts on that?
That's actually the thought of a lot of my colleagues. I don't really know how I feel about it because I try to put myself in other people's shoes. Like, well, what does that mean exactly? This is why I brought up Bill 30 there. I think it just bears close watching. But people do have to remember too that what does privatize mean? So this clinic that I'm sitting in right now, this is private healthcare. I'm a physician who subcontracts solely with the government. That's what I do. And that all physicians look like that to some degree. But the clinic is supported privately. This is not an HS facility. Most places that people go to get healthcare from a primary care are private clinics, so or privately held. They're non-profit outfits for the most part, right? That just support the place. When I spoke with the health minister in December, he had said, well, maybe one of the things that could be done is that business interests could help. As my colleague sitting next to me was like, oh, like, what does that mean? What does that mean? Do you mean that like a business would take over the running of our clinics, but would be for profit? And what would that business be? Who would that be? And why is that any better than what we have now? It's only better than what we have now if the the rules are changed so that it's more profitable for that business to operate. And that's, I'm not going to tinfoil hat it further than that here, though. I'm trying to stay my best in the here and now. But I think that the general person has a bit of a misconception about how the system even works.
So maybe instead of calling it private, we should call it for profit.
Yeah. Sure. Yeah, I think that would be appropriate. Yeah, and who's able to actually contract for with the government to provide healthcare, right? Are you a business that can then say, well, we're going to provide healthcare to these 8,000 people, and we'll do it however we see fit, and the government will pay us? Because that's new. Like, that might be a problem. I feel that has some potential drawbacks, right? Because that wasn't allowed until recently. I'm not a legal expert. I'm not a politician, and don't ask me to break down different bills and all these kinds of things. But that's what I see there. Yeah. Anyway.
Ian Hurdle, we finally trained enough doctors to start filling rural spots adequately in 2000, but now seem to rapidly leaving for elsewhere.
Yeah.
What are your comments on that?
It's just ultra sad. When I speak to my friends who work a little more rurally than I do, Lethbridge has problems. I think has potential for solutions that aren't really on the table for some of these smaller outfits and these smaller communities. I worry about them losing services. I worry about them losing the critical mass to work. I worry about the people working there right now getting burned out. You cannot go for a really long period of time and not have good conditions to attract physicians there, because if you lose a critical mass, you just won't be able to, for example, have an emergency room open consistently. You won't be able to deliver babies in a place. So you're really flirting with some disaster there. And once that's gone, to build it up from nothing is, I don't want to do that. That sounds terrible. Huge problem.
Okay. Bridge City News. What does having limited primary care mean for catching long-term illnesses early, and then in brackets cancer, etc., and perhaps saving lives?
Not perhaps, for sure. Absolutely saving lives. And we know that. There's research that states that the loss of robust primary care costs lives, and it increases costs. It leads to more poor health outcomes. It increases hospitalizations. It increases ER visits. And when I say increased costs, I'm talking both financially and in years of life. If you are somebody who's not having, well, I don't know, I'll choose something, colon cancer screening, right? Simple screening to do, but you have to be in the system to get it done. You have to have a medical home that will do it. We know that appropriate colorectal cancer screening saves lives if you do it across population. There are lives saved when we do it well. If people don't have a medical home, there's the pie chart of people who are getting cancer screening done, and you can extend this to diabetes screening and mental health and whatever you want. But in terms of getting this specific kind of screening done, just gets smaller and smaller and smaller. The amount of the pie, piece of pie, the people who are actually getting the work done decreases. And so there's some inequity there too. That is a problem. I haven't really even gone into that. So who gets a family doctor right now and who doesn't? But if you're part of the pie who doesn't get that screening, most people probably okay, right? But occasionally you're going to get someone who died or get a really significant illness that didn't have to. And why we're not talking about that right now is very frustrating, because we're talking a lot about ICU capacity. We're talking about that 2 years into a COVID pandemic, and we're saying, well, the solution to that is to have way more ICU capacity into the future. We need to be thinking about what's coming up in the next 5 years. And we're talking about getting knee replacements faster. Fine, yeah. But let's also talk about this, because it's not going to matter to a lot of people until it's them or someone they love and having a bad outcome because of something that should have been done, but it wasn't.
Okay. Next question comes from Pat Williams. Nurse practitioners can play an important role in primary care. Has anything changed in the ability of clinics to pay NPs?
Yeah, that's a good question. And you're absolutely right. Nurse practitioners can play a really critical role. There's a lot happening in that world here in Alberta right now. I'm not an expert in it, and so I'm going to defer a little bit here. But if I walk down the hall right now, I can go talk to our nurse practitioner here, who is supported by what's called our primary care network. And so at the moment, there's a big discussion happening in Alberta about the capacity of a nurse practitioner to hold their own patient panel to provide primary care. My own opinion on it is that, like a lot of things, these things work best in a team. So for the nurse practitioner that I work with, she does a little bit of primary care, but a lot of diabetes management and some of these other things, and it just works like an absolute charm. Without the person I'm thinking of, I'd be able to see far fewer patients and do it much less well. Integrating people like this into the team is going to be critical. I know that the health minister and that area are very interested in this. I'm just kind of waiting to hear more at the moment. I think there's great potential there to make primary care more robust, and we've done that. We've done that here in this clinic for sure. So I'm looking forward to see what the future holds there.
Bridge City News. You mentioned talking to Health Minister Copping about the current status of physician shortages here in Lethbridge. What are some of your ideas for ways to recruit and retain physicians to the city? A colleague of mine actually, I asked that exact question to many colleagues, and I asked it in writing. I said, tell me what you think. I think the best answer I got, and the one I resonate with the most, is that this needs to be, the issues with it are systemic, and because of that, they're province-wide. If those issues become addressed, Lethbridge should do fine. Lethbridge should do fine. But there's a lot of issues, and there's a lot stacked against us at the moment. I don't know about the capacity of the city itself to do recruitment. No one's asked me to sit on any committees, nor do I have a lot of time to do such things. But every idea that I come up with sort of butts up against what the capacity of a specific municipality actually is to do some of these things. And does it want to set precedent for some of these things? I'm not sure of the answers to those things. It's good. It's a really good question. It is, I think, the question, really. We could see with the coal mining issue, right? There were different mayors who reached out and said, we absolutely are opposed to this issue. It's going to affect our main source of drinking water and so on. And this is not a coal mining talk, obviously, but that had that made some waves, I think, right? And so I think if the members of a city, government and otherwise, reach out to the people who are able to deal with some of the issues that I've been talking about, that will have implications. Silence doesn't get you anything. I'm realizing we're quickly running out of time, so I'm going to skip a few questions and ask my last question. Dinesh Witharana, access to primary care workforce. Did I mess that up? Sorry.
No,
Okay.
it's fine.
Access to primary care workforce improves patient outcomes and decreases healthcare utilization, such as emergency room visits, hospitalization, and remissions, and healthcare costs. Family physicians provide the overwhelming majority, around 70% in Alberta, of all healthcare visits in Alberta and Canada.
Yeah, that's true. Yeah.
Adding family physicians to a population improves health outcomes greater than any other physician group. Yeah, so she goes on, but anyway, your comments, please.
That's all true. That's all true. There's not simple switches to make these things happen, but there are systemic reasons and cultural reasons why new graduates are not doing as much of this. There's reasons why it's fraying as badly as it has. I hope in the talk that I've given, I've gone over some of those reasons, and then people can draw their own conclusions as to what should be done about it. But it's so complex. It's so complex, but it doesn't really need to be. Just like anybody who wants to work in a job, what do they want? They want stability. They want to be able to go to their job, have fun with it, because medicine is a fun job, usually. Not always, but they don't want to spend all their time worrying about following, like I said earlier, the health minister on Twitter so they can know what they have to, what the conditions of their employment are the next day. That's not fun. That's not good. We need to be able to demand a little bit better. We need to be able to demand some stability here. But like I said, the main character of this story are the patients, is the people who don't have a place to go, and that's got to be fixed. That's got to be fixed. And the people who have the capacity to fix it know what to do, and they need to be asked to do it.
Right. Thank you so much. Before we wrap up, and I'm keenly aware of your time here, Doctor. Before we wrap up, do you have a take-home message for our viewers?
Don't take primary care for granted. We need to work together to fight for it. We in family medicine, we hear you. We hear the people calling out for help. We're doing what we can. We're doing our best to do what we can at the moment. Make sure you call out for help to the people who have the power to do some helpful things. And I have my fingers crossed that it'll get better. But a lot of it is out of my hands. But don't take primary care for granted. We need to cherish what we got. We need to make it stronger and better, and always advancing rather than regressing.
Well, excellent. Thank you on behalf of SACPOD. There's lots of thank yous in the queue. I'd like to read some out to you. Thank you for your presentation and providing context for how Lethbridge Primary Care is where it is today, by Laurie Schultz. Ian Hurdle. Thanks, Sam. Keeps your chin up. Great work, Dr. deWalle. Well spoken and thoughtful. Thank you for your great talk. I agree wholeheartedly that stability for the province is what will help Lethbridge. Any agreement with the AMA needs to specifically show tangible sorry for primary care. And on behalf of SACPA, thank you very much. Folks, next week we have a session on Tuesday evening. So we're really changing up times here. Tuesday evening, March 1st at 7 p.m. we have Dr. Maura Williams from Australia. She is joining us from Australia, the fight to end Australian coal mining. I hope you'll join us then. Thanks very much.